Good morning, everyone. My name is Shahira Amin, and I'm delighted to be with you here today on this very special occasion, the World Health Organization, WHO's 70th anniversary. And on this occasion, we have a panel discussion today on universal health coverage, everyone, everywhere. And that's the theme for World Health Day this year as well. Universal health doesn't just mean healthy individuals. It means citizens everywhere having access to quality health services without being exposed to financial hardship. We have a very distinguished group of global and regional public health experts as our panelists today. Please join me in welcoming Dr. Zafar Mirza. He is Director of Health Systems Development in the WHO Regional Office for the Eastern Mediterranean. Welcome, Dr. Mirza. Dr. Ruwaida Al-Maita, and she is a former Minister of Higher Education and Social Development in her home country, Jordan. Good to have you with us. Dr. Walid Ammar, he is Director General of Health, Lebanon. Mr. Abid Majid, he is Provincial Health Secretary from Pakistan. And Dr. Ahmed Kazim, last but not least, he is Director General of Specialized Medical Committees, and he will be overseeing the implementation of Egypt's new health insurance law. So, welcome everyone. Good to have you with us. I'd also like to welcome everyone who's joining us on Facebook, YouTube, and Twitter using the hashtag Health for All. Before we begin our discussion, I'd like to invite our host, Dr. Jawad Mahjour, the Acting Regional Director of WHO, to make the keynote opening announcement. Thank you, sir.
Thank you very much. Thank you for accepting to moderate this very important event. Excellencies, distinguished guests, representatives of the media, ladies and gentlemen, it is my honor and pleasure to welcome all of you on behalf of all the World Health Organization Regional Office staff to celebrate the World Health Day 2018. I would also like to welcome all those who are following the live stream on the event through our social media platforms. Today, we highlight a public health issue of great importance for each and everyone for us, universal health coverage. Everyone, everywhere, has a right to benefit from health services they need without falling into poverty when using them. This is our target, all of us. The year 2018 marks the WHO 70th anniversary and the 40th anniversary of the Alma-Ata Declaration on Primary Health Care, which set the goal of health for all. These two important events make the World Health Day this year a very special one, the theme of which is appropriately universal health coverage, everyone, everywhere. Health for all has always been WHO guiding vision, and our 70th anniversary is a reminder of that. Today, we are not only making a public health event, but also highlighting noble values such as equity, equality, and social fairness. By investing in universal health coverage and ensuring health for all, we contribute to bring there further for our countries and future generations. Universal health coverage is ambitious, but at the same time, it is feasible. Universal health coverage is not a dream for the future, it's a reality now. There is no one-size-fits-all, and countries are approaching universal health coverage in different ways. Some countries have made great progress. Their challenges now is to maintain coverage to meet people's expectations. On this occasion, I would like to extend my personal thanks and appreciation to our international and regional panelists who have joined us to shine light on this important subject, sharing their invaluable experience on the success stories they have been part of. Thank you very much for your attention.
Thank you very much, Dr. Mahjour. And now we have a short video, very, very short in Arabic and English, prepared by the WHO regional office here.
History is made by our achievements. We have come a long way to make the impossible possible. When we come together, lives are changed. Our next historic achievement is right in front of us. Health for all humankind. What if everyone had access to the health services they need and were not pushed into poverty, paying for it? Together, we can make health for all happen in our lifetime. It's time to make history again.
إنجازاتنا تصنع التاريخ. لقد قطعنا شوطاً طويلاً لنجعل المستحيل ممكناً. عندما نعمل معاً نغير حياة الناس. الإنجاز التاريخي القادم أمام أعيننا. الصحة لجميع الناس. ماذا لو حصل جميع الناس على الخدمات الصحية التي يحتاجون، وأن يتمكنوا من دفع ثمنها من دون الوقوع في براثن الفقر؟ معاً يمكننا أن نحقق هدف الصحة للجميع خلال حياتنا، لنصنع التاريخ مرة أخرى.
Universal health coverage, everyone, everywhere. That's the theme of World Health Day this year. It's also the topic of our panel discussion. But first, I have a surprise, and it's a nice surprise. We were able to get hold of the very first speech by the very first WHO regional director back in 1950, Dr. Tawfiq Shusha. And the speech actually was given to us by his granddaughter, who happens to be in the room with us here today. So, Samia, please, can you stand up for everyone to see you? And we want to recognize her, giving her a hand of applause. There is actually another granddaughter sitting right next to her, so we have two of them here. Thank you very much for joining us. And this is Dr. Tawfiq Shusha, who back in 1950 wrote this wonderful speech saying that the work done so far is particularly important in that it has laid the foundations of WHO activities in the Eastern Mediterranean region for years to come. Given the support of public health authorities and of the public, the health campaigns will be continuously expanded in the future, and they continue to be expanded to this day. That was back in 1950, 2 years after the establishment of WHO. Without further ado, let's begin our panel. And health is, of course, a human right. It is not just the absence of disease. Everyone, everywhere, is entitled to quality health care without discrimination and without having to be exposed to financial hardship. Governments are primarily responsible for organizing, financing, and leading health systems. But the private sector, development partners, and citizens too have a role to play in ensuring that health systems function well. The Sustainable Development Goal of achieving health for all by the year 2030 is an ambitious goal that can only be achieved through strong government commitment and public-private partnerships. Dr. Tedros, the Director General of WHO, says the universal health coverage is first and foremost a political choice that governments have to make. The Eastern Mediterranean region comprises 22 countries. It's a conflict-ridden region. It is also home to more than 50% of the world's refugees. It's also a diverse region with high, middle, and low-income countries. But even in some of the rich countries in the region, inequalities persist, with vulnerable populations being denied access to quality health services. Our region continues to be a low investor in health, and it's not for lack of resources. Some governments have yet to prioritize health over other issues on the development agenda, despite government expenses on health clearly being a high return investment and employment generator. How is the region faring with respect to universal health coverage? What is needed to implement the goal of health for all? And how is WHO supporting governments in the region to achieve this goal? We'll try and answer some of these questions and more on the panel. And let us begin with our guest from Geneva via video link, Dr. Anis Souket. I think she is already with us.
Yes.
Dr. Souket, good to have you with us. Is progress being made at the global level towards achieving the goal of health for all? Please tell us about some of the successful models and about the countries also lagging behind, and why are they lagging behind? Thank you.
Thank you very much, and let me express my gratitude for being part of this panel today and celebrating this extraordinary day where we are all aiming at health for all. And thanks for being part of this very distinguished panel. So, in a way, we should celebrate our achievements. The 20th century and the beginning of the 21st century have been times of extraordinary achievements. Health has been improving. We see child mortality going down all over the world. We see poor countries joining the curve of richer countries. We see poor groups having more access to services. So we are living at a time of great convergence. But it doesn't say that the job is achieved. We've seen this extraordinary progress stalling in many ways. Why? One of the key reasons is conflict, and this is really an issue in the Eastern Mediterranean region. Another one is the difficulty that we have to reach the poorest population, the disadvantaged, because of the time the social contract takes to develop. So a recent report of the WHO released in December last year tells us that if we estimate about what proportion of people in the world have access to health services, we can say that it's about half. That leaves us with another half. So as much as health indicators have improved, the child mortality has decreased, maternal mortality has decreased, we see progress on HIV, on malaria, and on other diseases. We see at the same time new challenges emerging, particularly the challenge of lifestyle disease, the challenge of aging, and we still have this vexing problem of difficulties in reaching the poor. So the progress, yes, but still some way to go, and particularly some way in reaching the unreached and getting this other half of the world to actually enjoy the same kind of access to services and the same rights that the richest half is enjoying today.
Disparities within countries. Some segments of the population are without access to quality health care. So what needs to be done to ensure that no one gets left behind?
So what we say when we in September 2015 as a global community, we committed to the Sustainable Development Goals, and universal health coverage is one of the goals that the UN General Assembly committed to. What we say is all people should have access to health services without financial hardship. So that it means that we have 15 years to really make progress on this ambitious goal, on this inspirational goal. And we have a lot of knowledge on how to go about it. We know that technically it is possible. We have the type of health services that can be delivered to all through basic primary health care, through family health services, but also good hospitals at reasonable cost. We also know that it is possible to reach the poor with some particular focused, targeted strategies. More than that, we published a report last year in WHO that actually estimates the cost of reaching this universal health coverage. And we found that most countries can actually do it. It is not that expensive. It is within the realm of what the economic growth is going to allow us to finance. Most countries will be able to finance universal health coverage. So then, if it is technically feasible, and if it is financially possible, we are really left with politics. And that's why this discussion today is so important, because it is about the social contract. It is about the solidarity mechanism. It's about the healthy paying for the sick. It's about the rich helping the poor. So it's really about each country developing the policies that will allow that kind of solidarity mechanism. And we know a lot of this can happen through taxation, progressive taxation, modern governments that subsidize health services, but it also requires quality health services in which the private sector has a very important role to play. So it's really about building the kind of partnership at country level that will foster the delivery of quality services with support of governments, with support of taxation, and expanding those services to those who don't have access to them right now, which generally are the most disadvantaged, the most rural, the peri-urban areas. So developing service delivery model that can reach these people is extremely important. But about all, having inclusive politics, having a national conversation through platforms of citizens who can agree together what kind of health services they want to finance collectively, what kind of collective decisions they want to make about which services should be allowed to all. This is really central. And this is why the role of people, both as a producer of their own health, but also as citizens, as having a voice in the public debate, is extremely important.
All right, stay with us, Dr. Souquet. We'll be coming back to you later. But now, Dr. Mirza, let's try and narrow down the discussion to this East Mediterranean region. 22 countries, 7 of which are in active conflicts. This has resulted in a huge refugee population. And as we mentioned earlier, it's a diverse region with high-income, low-income countries and middle-income like Egypt and Morocco. How is the East Mediterranean region faring, and what are the biggest challenges when achieving this goal?
Thank you very much, Shahira. And as one of the hosts, let me first greet our guests and distinguished panelists. We commemorate 7th of April as World Health Day to basically commemorate the foresightedness of our forefathers and foremothers who actually gave this world a global contract to pursue good health and well-being. And I think that it is worth a celebration. Anies Souquet mentioned about national contracts. or social contracts, we celebrate a global contract which was given to the world on 7th of August, 7th of April in 1948. So it's very auspicious occasion for us. Shahira, you mentioned about the region and diversity. Let me begin with diversity. It is indeed a very diverse region, 22 countries with remarkably different socio-economic conditions, political stability, tradition, ultimately, as the region and its countries are diverse, so are their health systems. Because health systems reflect all these in national settings. Just to ultimately say that health systems are what people and their leaders make choices for. And where the better choices have been made, we see better health. And where less desirable choices have been made, we see a continued mortality and mortality, which is actually preventable and avoidable, which is one of the biggest tragedies of our times. Let me also explain to you that you mentioned in the beginning that we are low spenders. So this region, which is about 635 million of people, represent about 10%, round about 10% of the population of the world. And yet, we are spending less than 2% of the global spending on health. So that itself explains that where the gap is, where the problem is. Now when we spend less, this also means that people do not get the services they require. And especially when governments are spending less, and when people go to public health sector facilities and they don't find what they need, they turn to private health sector. And as a result of that, especially the poor people, they end up spending their very, very hard-earned, shallow incomes on very high-costed healthcare. And just to elaborate it a little bit more, we have estimated and reported last year that in this region, around about 55.5 million people go through financial hardship when they access healthcare. And even more disturbing than this is that around about 7.8 million people actually become poor just because they have to pay for health. We call it impoverishing health expenditures. They are already on the brink of poverty. When they have to make these expenditures, they fall below the poverty line. And that is absolutely not acceptable. So these things are happening, and we are actually on the top of all this. We have emergencies going on. We are house of world refugees, internally displaced people, and this is putting a lot of pressure on already stretched health systems. Now, I might be painting a very bleak picture of the region. Let me turn to the positive side of it. In the midst of this adversity, we also see examples of marvelous attempts which are being made by national governments to improve the health systems and the healthcare of people. Our high-income countries, GCC and the upper middle income countries, Iran, Morocco, and a couple of other countries, they have already achieved near to universal health coverage. Our middle income countries are making great efforts to provide financial protection by putting more money into it and by using the money available in a better way. So in order to organize systems, prepaid systems for poor people, that when they go for their health care, they don't have to worry that whether they have got money in their pockets or not. And I think these are very, very appreciable examples. Lastly, what I would also say, that especially after our governments have signed 2030 Agenda for Sustainable Development in this region, there is a new energy we see. There is a new momentum that governments are really now putting forward their efforts to improve the living conditions and the social conditions of our people, and which is very, very highly appreciable. And we are proud to be part of those efforts in terms of facilitating those systems to take root.
Dr. Almaita, you are from Jordan, and Jordan is a small country of 7 million people, but it hosts 2 million refugees from Syria and Iraq, in addition to the Palestinian refugees. So Jordan may be overstretching its resources to provide medical care for the refugees. How is it coping, and what are the challenges?
يتم إنفاقها لتقديم الرعاية الصحية. كيف يكون هذا الأمر؟ في الوقت الحالي أن الأردن تنعم الأردن بالاستقرار السياسي، ولكن أنت تتحدثين عن العراق وسوريا فلسطين. أننا لدينا أكثر من 2 مليون لاجئ، لدينا 3 ملايين لاجئ، وبالطبع
of the refugees from the different countries, they cause a lot of pressure on all our resources. And you know that in Jordan actually we do have limited resources, especially when we talk about energy, we talk about water and others. So for now they are also having too much pressure, and actually it is a burden on the education as well as the health system.
Global support been forthcoming?
This is another issue that maybe I'll talk about it later, but I'm going to talk about even with this, you know, this is one of the things that I would like to clarify, that Jordan never, you know, closed the borders from a humane point of view. It's always open, regardless that, you know, the international community have not actually met their commitment to Jordan and to many other countries, Lebanon and Turkey and some other countries. But you know, they had very many promises in the past, and actually it met maybe only 10%. So in Jordan we have a huge budget gap actually from the funding, international
كبيرة فيما يتعلق بالتمويل الدولي لقطاع الصحة، وفيما يتعلق باللاجئين. لدينا 90% من السوريين يعيشون خارج المعسكرات، يعيشون داخل الأردن، وهناك مرونة في التعامل. مع ذلك ربما لا يكون هناك متابعة جيدة لهذا الأمر، ولكن يكون علينا أن نعاونهم وأن نوفر لهم التعليم والصحة، وأن تكون هناك مرونة في التعامل معهم.
Syrian in Jordan. Of course, you know, with all the refugees, you know that it also affected the growth of the population, you know, from both sides, the Jordanians as well as the refugees. And of course, you know, it has all, you know, implicated in the health services. So far, we have about 30% of the population in Jordan, they are non-Jordanians. There are people from outside. So just imagine, you know, how much, you know,
من الخارج، وعليكم أن تتخيلوا كيف أن هذا يمثل عبئا وضغطا على الأردن.
Education system, we have now two actually parts of education, one in the morning and one 2 sessions and one in the afternoon.
نظام التعليم لهؤلاء هناك دورة صباحية ودورة مسائية،
in the community, in the transportation, and in everything. But with that, every time we have problem, we shoot that problem and we find the right solution. Because again, in Jordan, we were talking about some of the issues. The majority of the Jordanians, they perceive the refugees as guests in Jordan. So that's I think very important. And the first time that they came to Jordan, the Syrians and some others also, they hosted them in their own houses. I remember when they started, very many people, like, they have to empty 2 rooms for them. People they know and people they don't know, especially in the north area, because, the first, place that they, come to Jordan is through the northern area. So that was, I think very important. There are many challenges, of course, and now, the challenges after 7 years, of the Syrian crisis, I think, it's increasing. Also with the lack of funds from the international community, all these things, it tells us that, we have to be, really prepared, because with the political situation, everything is unpredictable, especially if what we have, around the world now.
Lebanon is a country that is heavily private sector dominated with respect to health. Does that put healthcare beyond the reach of the average citizen?
What's important in universal health coverage is
برجاء الحديث
to
في
make
الميكروفون
services available,
لكي
accessible,
نتيح الخدمات
and affordable to everybody
بتكلفة
whenever they need the service.
معقولة للجميع.
And whether these services are totally provided by the government
إما أن هذه
or
الخدمات
partially
تقدم
or mostly
بالكامل
provided by
من
other
الحكومة أو
actors
تقدم من
doesn't
جانب
really matter
لاعبين
as far as
آخرين
you can control the quality and the cost,
وأن
and you can make
هذه
sure that
المسألة أيضا
people
تتعلق
are not facing financial
بجودة
hardship
الخدمات
when accessing health services.
والتكلفة
Dealing
وبالطبع
with the
أن
private sector,
هناك أناس
financing
لا
is crucial.
يستطيعون
In
النفاذ
Lebanon,
إلى
we have
هذه
half of the population
الخدمات،
that is
ولذلك
enrolled
فإن
in the
القطاع
Social
الخاص
Security Fund or other
يلعب
public insurance schemes,
دورا
and these are
مهما
people that are
في
working in
ذلك،
the formal sector.
وأن
And
هناك
the other
أناس
half is entitled to
يعملون
the
في
Ministry
القطاع
of Public Health.
الرسمي،
The first half is
وأن
financed by
وزارة الصحة
contributions of
العامة
employers and employees,
تحصل على
and the half covered by the ministry
مساهمات
is
من
covered by
الحكومة
money coming from the government
الحكومة أو من الميزانية الحكومة ومن
owns only
الضرائب
15% of health facilities in
التي
the country.
يتم
So it
الحصول
doesn't have
عليها،
other choice than
ولذلك
contracting with the
فإنه
private sector, whether the
لا
private
يكون أمامنا
for-profit
سوى
or the
خيار
NGOs.
مشاركة القطاع الخاص
And
ومنظمات غير
Does it regulate the growth of the private sector? Is it part of the government's planning process?
وهل يكون القطاع الخاص جزء
regulation is
من
the
خطة
key
الحكومة؟
word.
نعم هناك
the private sector, the
لوائح
private for-profit is
تنظم،
very
فإن
good in investing in secondary and tertiary care and
القطاع
integrating
الخاص
technology.
يقوم
And this kind of services is
بالاستثمار
needed.
وأيضا في المجال
And on the
التكنولوجي
other hand,
مما
the Ministry of Health
يتيح خدمات
does not
كما أن
reimburse ambulatory care, but provide
وزارة الصحة
primary health care through a network of primary health care centers
تقدم
in collaboration with
الخدمات
NGOs and
الصحية
municipalities.
الأولية
Civil
في
society organizations are the
المراكز
best allies
الصحية،
to government
وأيضا
when it
أن
comes
القطاع
to
الخاص
promoting
يساعد
preventive and
الحكومة
primary
وذلك من أجل تحسين الصحة وتحقيق
and municipalities is important because decentralization is important. So for universal health coverage, dealing with NGOs and municipalities that are close to the community and making services people-centered services is really crucial. So in short, it is really very important to diversify either the sources of financing or the provision of services, the actors in providing services, but the key word is regulation.
فيما
Let me just remind you that you have Arabic translation for those of you that need it. It's just a click away. The Arabic is on channel 1 and the English is channel 2. Dr. Kazim, Egypt has recently passed a new health insurance law, Mabruk. It's a milestone towards achieving universal health coverage. The law will first be applied, as I understand, in 5 governorates. Why were these particular governorates chosen? And yes, I'll be asking you about the funding a little later on, but first let's start.
لك هذا السؤال فيما بعد ولكن
for comprehensive health insurance system in Egypt, we have been dealing with the issue for more than 10 years in order to develop a national system for comprehensive health insurance. Lately, over the last 4 years, there had been a political commitment that comprehensive health insurance should see daylight through Parliament. This has been done through the endeavors that had been exerted by many of our friends here, including our representative of the Finance Minister, Dr. Alman, also Dr. Ghida Anwar as well, all those people who had been leading in this drive for this law to see daylight. It had been passed by Parliament. It's going to be implemented as of the 1st of July in the Governorate of Port Said. It's going to be in 6 phases until complete coverage of all governorates of Egypt. It will take something like 12 to 15 years. This kind of progressive implementation gives more strength to the system because it needs a reassessment of each and every stage that we have been going through in order to improve the system during the forthcoming stages. This also means that we do not allocate all our money to a specific governorate just in case there had been any failing. This could lead to a failure in the whole system, and this is something we don't want to have.
بالطبع أن هذا يساعد مصر ويدعوها على الطريق الصحيح.
Mr. Majid, you are part of a major program ensuring universal health coverage in your province, KB. It's the second biggest province in Pakistan. Tell us how you're doing it. How are you mobilizing resources, and how do you decide which segments of the population get services first?
قطاع من السكان الذين يحصلون على هذه الخدمات.
One was reducing out-of-pocket expenditure.
في الواقع كانت أول نقطة هي خفض الإنفاق، وهكذا قمنا بتخفيض الإنفاق على باقي الخدمات الأخرى، ومن هنا قمنا بتعضيد الخدمات الصحية. بدأنا ب 30 مليون ثم وصلنا إلى 300 مليون.
We realized that in 4 years, even if you double the budget, the gaps are so much that there will be one fine morning where you won't have further money.
بعض الأموال المتوفرة من أجل العناية الصحية، لماذا؟ لأن عدد كبير من الناس يحتاجون إلى هذه النفقات، التعليم كذلك، وهكذا بدأنا السمارت فاينانسينج أي التمويل الذكي، وبهذا غيرنا المعدل من حوالي 10% حتى 26%. وهكذا وبالنسبة للرعاية الصحية الثانوية وصلنا إلى 28% بالمقارنة للعام الماضي، ولهذا كانت هناك مباني كبيرة جدا وفرص عمل كبيرة جدا أيضا، وهكذا زاد بروز هذه الخدمات. ثم بدأنا بعد ذلك العمل على زيادة عدد الأطباء والممرضات وكذلك كل من يعملون في مساعدة الأطباء وكذلك القابلات، وهذا ساعدنا كثيرا. ثم بعد ذلك قمنا بدعم المعدات نفسها التي نقدم من خلالها ذلك الدعم
with nutrition program because
بدأنا
$1 spent
ببرامج
in nutrition
تغذية
now
جديدة من
is
أجل رفع
actually going to
تغذية
save you
طلاب
12 or
المدارس
15 or 20
والأطفال
later and also
ووصلنا
have a
إلى
very healthy
تحسين
workforce for the future. And then with WHO's help, and I appreciate
وبخدمة
Dr.
منظمة
Asai for
الصحة
that because he
العالمية
supported us a
أيضا
lot. We started doing family
بدأنا في
practice. We
القيام
have just started it.
بالممارسات
It will not only have
العائلية
a
أي
proper
من أسرة
filtration
إلى
mechanism
أسرة
for the
بدأنا
unnecessary and
بتصفية
necessary referrals,
الخدمات
but it will
التي
also be
نقدمها فهناك بعض
initiative which will
التحويلات
go
أو
for
الإحالات
non-communicable
إلى
diseases
المستشفى لا
control.
تستحق هذه
And
الخدمة
lastly,
وهكذا
when
قمنا
we found out
بتصفية
that
الخدمات
reforms take time and
ومؤخرا
people don't have the
قمنا
patience for that
عرفنا
time
أن
because everybody
الإعداد
wants everything to be
والإحالة
there
أيضا
immediately.
المستشفيات
So
يستغرق
we
وقتا
thought we'll go
طويلا
for having
فقمنا
a scheme of social health
بإرساء
protection to
خطة
avoid catastrophic
لارتفاع
and in that now
بصحة
what we have done
السكان
is we have
وبالنسبة لما
covered
قمنا به
69%
حتى
of the
الآن قمنا
population because we
بتغطية
have gone for $2 or
69%
below income
لهؤلاء
between the
الذين
poor,
يصل دخلهم
and we
إلى
have
أقل
had
من
an essential health
$100
services package
وهذا
that takes care
بالطبع
of their
يستغرق
treatment in
وقتا
secondary and
طويلا
tertiary care both.
ويأخذ أموالا
And we have
كثيرة
included
أيضا
the private sector in it
وكذلك
because we are
قمنا
a firm
بإشراك
believer in
القطاع
this that
الخاص في
with these
عملنا
requirements of health,
وبهذه
the public
المتطلبات
sector
الكبيرة
alone cannot do
للصحة
it.
لا يمكن
Probably
أبدا
in most of
للقطاع
the
العام
cases
أن
if we
يقوم
don't
به
go for
وحده
public-private partnership
وهكذا فإن القطاع
of
الخاص
service delivery
والشراكة ما بين
packages,
القطاعين
it costs
العام
much
والخاص
more in the public sector to provide a
يقدم لنا
particular
الخدمات
facility. And I'll
الناقصة
give you a
ويسد
very rough
الفجوة
example of this Uber service even.
وهكذا مثلا
If you
ترون أن
maintain a
خدمة
car, have a
أوبر هي
driver, have
نموذج جيد
everything, it
جدا
will cost you more. But
للمساعدة أو
if you have
الشراكة ما بين
services
القطاعين
which
العام
can be
والخاص
outsourced,
وكيف أنك
which say
يمكنك
when,
أن تطلب
where, and how
أحدا
much,
يقدم لك
that is far
تعهيدا
better
أو
for you.
الخدمة من خارج
So I'll
المؤسسة
end it with the fact that we are taking
وهكذا
those
وصلنا إلى
really
حقيقة
important
مفادها
steps
أننا
towards
وصلنا إلى
universal health
خطوات
coverage.
مهمة جدا
Our
لتحسين
next
التغطية
5-year
الصحية
strategy
الشاملة
is
وعلى
one
مدى
pager with 3
ال5
words on
سنوات
it:
القادمة
universal health coverage. And
سوف
that's it.
نحقق استراتيجيتنا الجديدة
Really promising and
هذا
excellent.
بالفعل خطة
like
واعدة
success story
ورائعة
there.
وهي
But
قصة
Pakistan,
نجاح
like Lebanon,
ولكن
like
باكستان
Jordan,
مثل
like
لبنان
Egypt,
والأردن ومصر
has been hosting
كذلك
refugees mainly
كانت
from
ما زالت
Afghanistan.
تستضيف
This
عددا
often
كبيرا
comes at
من
the cost of the
اللاجئين
local
هذا يكون
population.
أحيانا على حساب السكان
What's being
المحليين
done to
فما
ensure
الذي
that the
تقومون به من
vulnerable
أجل
populations,
ضمان
the poor
هذه
and the
الخدمة
refugees,
وكذلك
have
كيف لا يؤثر ذلك على الفقراء من سكان
In
البلاد
Pakistan, then Khyber Pakhtunkhwa,
يقول
the province
في
to which I
الواقع في
belong,
باكستان
actually bore the, I won't say the brunt, but had the honor also of hosting them.
نحن
And we
نستضيف
had and we still have
هؤلاء
that same
اللاجئين
strategy where they
وينخرطون في
are allowed and
مجتمعاتنا
eligible to
وهم
the same
مسموح
outdoor and indoor
لهم
facilities
أن
in our
يحصلوا على
tertiary care
نفس
hospitals
الخدمات
even,
الصحية
because there are
سواء
Muslim
كانت
children
الخدمة
and there are
الصحية في
neighbors also.
المنزل أم
Now
الخدمة
we
الصحية
have
في
particular
المستشفيات
schemes running with
وكذلك
donor
لدينا
interventions
خطط
also,
كثيرة
which
جدا نقوم
actually
بها
put in a lot of effort into
وهي
the
التي
areas
نبذل
which have
فيها
been
جهدا
affected by the
كبيرا جدا
refugees, the health
وبصفة
facilities that
خاصة
have
في
been
المناطق
affected by the
التي
refugees.
تتكاثر فيها
So
أعداد اللاجئين
while there is no social
فبينما لا
health
يكون
protection or
هناك
anything else for
حماية
refugees,
صحية
I think
للاجئين أعتقد
they are getting
أعتقد
100%
أنهم يحصلون الآن على 100% من
because their
خدمات
treatment
التأمين
is free across
الصحي
Pakistan.
لأن الخدمة الصحية هناك مجانية.
So their 100% treatment is free in Pakistan, and as long as they stay there, it will be 100% free.
Dr. Suket, back to you.
نعود إليك سيدتي.
As an economist, you know better than
خبيرة
most of us
اقتصادية فأنت تعلمين
that
أكثر
government
منا جميعا
expenditure
الإنفاق
in health
الحكومي
is a
على
very
الصحة
worthwhile
وأنه
investment.
بالفعل استثمار
Yet some
ناجح.
countries are not allocating
ولكن بعض
enough
الدول لا
funds
تخصص أموالا كافية
to health in their national budgets.
للصحة
Is
في
universal
الموازنة
health
العامة.
coverage possible
هل التغطية
in
الصحية
poor
الشاملة
countries
ممكنة في
as
الدول
it is in
الفقيرة
the rich
كما هي في
countries?
الدول الغنية؟ لا يمكننا أن نسمعها للأسف، هناك خلل في الصوت.
Can you try again?
هل من الممكن أن نحاول مرة أخرى؟
We'll come back to you
سنعود إليك مرة أخرى
as
سيدتي
they
حين
sort out this
نصلح
problem with
هذا
the sound
الخطأ
here with the video link.
الفني.
Dr.
هذا
Zafar,
العطل الفني. دكتور زافر،
health services are
إن الخدمات
seriously
الصحية
affected in
متأثرة تأثرا
emergency
كبيرا في
situations,
حالات
which, as
الطوارئ،
you said, are not
والتي كما
uncommon in this
قلت
region.
هي سائدة
WHO
وشائعة
is
في هذا
committed to
الإقليم، ومنظمة
providing
الصحة العالمية
emergency
ملتزمة
care
بتقديم
services.
هذه الخدمات في
What
حالات
else is
الطوارئ.
WHO
ما الذي
doing
تقوم
تقوم به منظمة الصحة العالمية أيضا من أجل دعم الحكومات في هذا الإقليم.
Thank you, Shahira.
شكرا لك شهيرة.
Let me first take this
أولا
opportunity
أنتهز
to
هذه الفرصة
appreciate
لكي وأعرب
what
عن
we have just
تقديري
heard from
لما
our
استمعنا
panelists.
إليه من صديقنا
This
هنا
province, KP province in
في
Pakistan,
إقليم KP
increasing
في
their budget
باكستان
3
حيث
times.
زيادة
It is unprecedented,
مضاعفة موازنة
in
الرعاية الصحية
the health
3
history
أضعاف
of
على مدى
the country.
تاريخ الدولة.
Egypt
ومصر كذلك
introducing social health insurance
تقدم
law, a
الآن
historical
قانونا
milestone.
جديدا
And I would
للرعاية
really
الصحية
like
أو
to
للتأمين
congratulate
الصحي،
the
وأنا
Minister
أود
of
من هنا
Finance, who is
أن
His Excellency sitting with us,
أحيي
and he came
معالي
to just to listen to this, which shows the commitment that Egypt right now has for the health sector and the health of its
وهكذا
people.
فنحن في هذا المجال
What
نحيي كل تلك
WHO is
الدول
doing,
التي
let me
بذلت
begin
مجهودها.
from first give
فأبدأ
you
الآن
by
أولاً
giving
بأن
you a
أقدم
global
لكم
understanding
الفهم
that how
العالمي لهذا
WHO as an
الأمر.
organization
فمنظمة
is
الصحة
approaching it.
العالمية كمنظمة
You know
تقوم
that
بذلك
now we have
الكل.
new
والآن
leadership,
لدينا
Dr.
قيادة
Tedros,
جديدة،
our new
الدكتور
Director
تدرس
General.
وهو المدير العام
For
الجديد.
him, and he has
بالنسبة
repeatedly
له
said this,
وهو الذي قال
that
ذلك مرارا
universal health
أن
coverage
توفير
is my
الصحة
top
الشاملة
priority.
هي
So it's a
أولويته
leadership priority.
القصوى. إذن
And
فهي
we
إرادة
have to
سياسية،
reflect
وعلينا
whatever
أن
we do,
نعبر عن
and it
كل ما
includes
نقوم
not just
به
health systems, it
بحيث لا
includes
نغطي
communicable disease
النظم
departments,
الصحية فقط، ولكن
non-communicable
كذلك
disease departments,
أقسام الأمراض
emergency
السارية والأمراض
departments,
غير السارية،
and mother and
وكذلك
child healthcare
أقسام الطوارئ
colleagues who are
وخدمة
working on it.
الأم
They have to
والطفل.
see
يجب
that whatever they do,
نرى أن ما
how
يقومون
they
به
assist national governments in
يؤثر
order to
على
advance universal health.
المجتمعات وكيف أن الإرادة
So
السياسية
what
لها دور
he
كبير.
has given us a new mission,
فإذا
and the mission
المهمة
is actually
التي
very
وكلت
smart.
إلينا بالفعل هي
It
مهمة
is
ذكية
promote
جدا،
health,
وهي دعم
keep the
الصحة
world safe, and serve the
وتأمين
vulnerable.
العالم وكذلك
And actually
خدمة الفقراء والمهمشين.
this mission
هذه
is now
المهمة
the power engine for
أصبحت
WHO
هي
to actually
الحرك
reorganize
وراء
ourselves,
منظمة
which
الصحة
also
العالمية
means
التي
transforming
ننظمها.
WHO
فهي
itself
التي
to
تحول
reorganize ourselves
مسار منظمة
to be
الصحة
more
العالمية.
effective
نحن يجب
in
أن
our
ننظم
assistance to
صفوفنا
our member
لكي نكون
states.
قادرين على خدمة
Now,
الدول الأعضاء.
having said this, it is also very important to understand that countries will move towards universal health coverage at a different speed, depending upon what the conditions are and what resources are available. But the key message here is that universal health coverage, the word universal is very important, not just for everybody in the country, but every country also, which means that every country has this obligation, because they are now signatory to 2030 Agenda for Sustainable Development, and target to achieve universal health coverage by 2030 is a target which is embedded in Goal 3 of Sustainable Development Agenda. Now, as somebody said earlier, that it begins with political commitment. And our Dr. Tedros say that universal health coverage, first and foremost, is a political choice. You first have to decide that you want to do it. Once you decide it, you will find means. There is enough technology available. There are enough good examples and good global practices available. There are enough national experiences available from where we can learn from. But you first have to decide this and develop this vision that we want to do it. Now, once you have done that, then we also know that the most important thing which will enable countries to move towards universal health coverage are their health care systems, health systems. And health systems have to be strengthened. Our financing strategies need to be reoriented in order for them to provide financial protection. Our integrated service delivery has to really start working in order to provide essential health services to people. Our information systems need to work, our health workforce needs to be reorganized, and so on and so forth. So there are a number of things that WHO is doing in all these areas with our member states in order to assist them in taking steps towards universal health coverage. And I can give you many examples, but let me finish this by a very positive story. Very briefly. In 2016, we went to Iran to actually evaluate their health transformation plan, which, by the way, Iran provides 100% universal health coverage to rural populations and 95% financial protection for all its population. And they had decided a target that they are going to achieve 100% financial protection for all their population by 2030. This is 2016. In 2017, when we went there and we were informed that actually government has reconsidered their target and they have decided that instead of 2030, we are going to achieve it in 2025. So these are the kind of, positive stories and examples and initiatives which are being taken in the region, despite of so much adversity, despite of so much emergency which is going on. I think we are really braving our way, and our government needs to be appreciated for that. Thank you.
Thank you, Dr. Mirza. Well, Egypt has decided there is definitely the political will and high-level commitment. Now we have the law that's been passed in mid-December, health insurance law. Where will the funding come from?
The funding is going to come from 3 institutions, not just one. One which is responsible for your universal coverage and is going to assume the responsibility of financing the system. And this institution or this authority is going to be responsible to collect the subscriptions. The other one is going to be responsible for accreditation, and the third one is going to be for health care and to provide health services. Regarding funding, according to the new law, the head of the family is not going to depend on disparate laws, but there are laws governing subscribers, and those also for schools and for employees as well, and the subscription for the people on pension, and subscription also for the women head of families. All this is going to come under one authority, which is going to be the head of the family. The family or the bread earner is going to be responsible to, and according to an actual study, the father and sons, as well as the wife and those that are in charge of the husband. It's going to be a comprehensive family covered by subscriptions. According to the new law, the directives there will not be any fragmentation regarding all subscriptions. Everyone, we shall not have a multiple system, and this is going to give an impetus to the budget regarding the current health security.
I hope, Dr. Now, the question was, is universal health coverage possible in the poor country as it is in the rich? No? Okay. I'm afraid we're not hearing you. I'm very sorry about that. But perhaps Dr. Mirza, you can answer that question.
Thank you. Thank you very much. It's a pity that we cannot hear but I will try to answer this question. Absolutely. As I earlier said, universal health coverage is for every country. Every country can take steps which are more appropriate within the given resources, within the given conditions that they have. I give you an example. Who is the largest spender on health in this world? Can anybody tell me who is the largest spender on health in the world? It's United States of America. They spend round about 9,000 US dollars per capita. That is about 18% of their GDP, and it's a big GDP we are talking about
يمثل
on health.
18% من إجمالي
Do everybody in
الناتج
America has
المحلي
healthcare?
في
Actually,
الصحة
more than 40
أين كل
million
شخص
people
يتم
in United
تغطيته
States of America
صحيا
do not have health
لا
insurance,
يوجد
which means
أحد
that they do not have guaranteed access to healthcare.
تأمين
Now I give you an example of a country which is spending much less than this, but can claim that they have provided decent healthcare to their citizens. I give you an example of Thailand. Spending around about $300 per capita. In 2002, they could actually establish that they have achieved universal health coverage for all their population. So it's not a question of just money. It's a question of what you want to do. Do you have a vision? Have you prioritized the health needs of your people? And are you ready to invest in them? So I mean, people usually make this, people overstate this issue that since there is an issue of resources, we cannot do this. I will also give you an example of Rwanda, which is actually spending around about $60 per capita. And they can also claim that they are very close to providing universal health coverage, which consists of all the basic health services to their mothers, to their children, to their old people, and they have actually transformed their health system in the last couple of years. And this is a country which emerged a huge tragedy of genocide in 90s. But when they decided it, they did it. So it's, universal health coverage is not only for affluent countries. It is for everybody. It is possible. You just have to make the right choices at the right time and be consistent and sustainable in what you do, and you will reach your goal. Thank you.
Well, we just have time for a couple more questions, so I think I'll put this question to both of you. Prevention is, of course, more cost-effective than cure. What else works?
Yes, you're right. Promotion and prevention is much more cost-effective. And if you look at the budget of practically all the countries, they put much more money on the curative side than on the prevention. And this is because people, they are asking for more curative care, they are asking for more technology, and they are not really aware about the prevention and promotion side of health. And this brings me to an issue that is important. Now we are celebrating, WHO is celebrating the 40th anniversary of primary health care, Al-Ma'ata Declaration, Health for All. And I'm not sure that an analysis was done why this goal was not achieved in the year 2000 as was expected. And now we are having a new goal, actually the same in other words, which is universal health coverage. And we are talking more and more about people-centered care, and I'm not sure if we are aware what people want. People want quality care, people want technology, people are informed, they are asking for new medicine and new technology. And the approach of WHO and all the other countries, including my approach, is rather normative. And I think it is time to have some coherence between, normative needs, people's expectations, and availability of resources. And this needs a societal dialogue, and this depends on the context and history of each country.
I'll just add another aspect to it. Whenever we talk of prevention, I've seen it in
working against dengue. The previous year we were facing that. It's the health sector which is thought to be responsible. It's not like that. 95% of the time, it's not the health sector. It's the issue of climatic change. It's also the issue of water supply and sanitation. It's also the issue of unplanned urbanization that is going on. So there are other sectors and departments. So one of the things that's not seen in prevention is an integrated approach, not within the health sector, but amongst the sectors. I'll just point out that and say that an integrated approach is required, which actually takes this prevention thing forward.
I'm told that Dr. Sukhet, the sound has been fixed, so would you kindly answer the question? Unfortunately, we cannot hear you. Dr. Almaita, universal health coverage is not just about curative services. Communicable disease patients among refugee populations can easily turn it into disease outbreaks, even epidemics that could envelope the population. What is Jordan doing about that to control communicable diseases and protect its population?
Thank you very much, but first I would like to elaborate on what was said, because I think when we talk about strengthening health system, we're talking about technology, we're talking about the services, but we should not forget to know the capacity building of the health workforce. This is very important. We have the high level commission in health employment and economic growth, which was held actually 2 years ago. They came up with the importance of investing in the health workforce. And now with the WHO, as well as the ICN, as well as the Nursing Now initiative, now they're focusing on the nurses, to enhance nurses at the globe actually, and to improve their position also at the heart of policymaking. This is one. The other thing also for the primary health services, as well as the promotion and prevention, is very important actually, is to, to influence the culture of people, to try to change the culture of people. In Jordan, we have the best list actually of services, and it's everywhere. You find in every single, even the very remote areas, you have healthcare centers. But people are also like to go to hospitals. This is how they practice. So I think that also the governments, I'm talking about some other maybe countries in the world, they have to make it more attractive for people to come. And then this also at the heart of the communicable disease, because it is again it is part of concern all over the world. In Jordan, we developed strategy for that, and the refugees are part of that strategy. And of more importance now, we are so happy that the SDGs, they have the mental health actual component in it, and it was not there. So the communicable diseases as well as mental health, they are now part of the SDGs. One thing that I would like also to elaborate is going back, we need to invest in health. Why? Because the investing in health is not only limited to positive health outcomes. It has also economic returns and also social returns. That's why when we invest in the universal health coverage, it means that we are investing in human capital, which also leads to the sustainable growth development, and this is, I think, very important. And also, it will also enhance the global security and the national security. The other thing also, I'm so happy that you're doing the media, and you call it you said it's a media plenary session. I think I have a message for all journalists and media. Without the support of the media and the journalists, and we know that media is a very powerful tool to influence policymakers and politicians. And I'm sorry, I'm saying that, for one of the Ministry of the Finance here. I think it's very important to reflect the public agenda in the media agenda in order to influence the political agenda. They have very important role also to lead journalists, the media, to lead, to inspire, and to enhance and influence the policymakers' decision. I think this is very important. For me, if we're going to take just, a look back on the human rights, I think I read in many places that we have to have framework for, the ethical framework for the universal health coverage and all health services. But for me, I think that the universal health coverage by itself, it is the ethical actually framework for health services. That's, my message is that we really need to invest. We really have to have, all hands together from journalists, from the people, from the private sector, from the government, from politicians, because again, ministers of health, they cannot do it alone. And healthcare providers alone, they cannot do it alone without, like we said, without, the intersectoral actually collaboration and cooperation, and without political will. We're so happy that in Jordan we have, the political will. We have another system actually. You are doing like, governorates. In Jordan, we've taken the ages actually. So now we have 65 and above, they are all insured. We have 6 use analysts, they are all insured. And we have a plan to bring the down and up together. We have very good plan for that.
وهذا ما عملنا عليه خلال السنوات الماضية. دكتور سكات، نعود إليك، هل تسمعينني؟
للأسف هذا سؤال أخير سوف أحتفظ به حول التعاون والجهود التي بذلتها كافة المؤسسات والمنظمات الدولية والشريكة في التنمية، وهي التي تحاول من تقوية النظام الصحي في الإقليم. هل هناك من تنسيق جيد ما بين الجهود يا دكتور ميرزا ما بين كافة المؤسسات؟ في الواقع إن ذلك تحدي كبير دائما، ولكن منظمة الصحة العالمية أصبحت الآن في وضع القيادة من أجل تنسيق هذه الجهود، وأيضا بالنسبة للتغطية الصحية الشاملة قمنا بتأسيس شراكة دولية.
And this partnership we call UHC 2030 partnership. And it is building on actually our previous work, which was International Health Partnership Plus. And UHC 2030 partnership is basically urging to bring all health partners around the table to agree on same approach, on same plan, on same budget, and to support the government according to the national priorities. And in some countries, it has started working. From our region, I will give you an example of, for example, Sudan, where there is a now very vibrant health partners forum which has been created, and which have recently actually done second national health assessment jointly. So when you do a joint assessment, then you also own the results of that assessment. And once you know the problems, then you also know that how to invest and where to invest and how much to invest. And this is not just Sudan. In Jordan also, we have a very good forum of the health partners. And in a couple of other countries, it is also now taking root. The 17th goal of SDGs is about partnerships. And sustainable development including in health, cannot take place if there is no intersectoral action. And especially in health, because we are dependent, we contribute heavily to other sectors and we benefit from other sectors when they grow and when they develop. So intersectoral collaboration is absolutely very critical, and the good news is that now through academic work, which we call DCP3, Disease Control Priorities, in which we have actually developed a list of about 70 intersectoral interventions which needs to be made in order to develop our health systems. And we exactly know that what needs to be done at intersectoral level, and which require all parties to work together. One maybe last thing which I would also like to say, that the agenda of universal health coverage cannot advance in the context of high out-of-pocket expenditures, which means that the public spending on health is low without effective engagement with private health sector. And that is absolutely very important. Private health sector needs to be partnered. This does not mean that we stop regulating them. We have to regulate them, but we also need to develop our terms of engagement with private health sector so that they become partners in service delivery. Thank you.
Very important key messages there: the political will, public-private partnerships, and better coordination between the development partners. Before I thank our panelists, I think I'll give a chance for people from the room to ask questions. Please state which panelist you're addressing your question to, and you can use any language, Arabic or English. I see that His Excellency has just stepped back in the room. His Excellency, the Minister of Finance, perhaps would like to say a few words.
Thank you very much, and let me start by congratulating the WHO on celebrating the 70th year for Health for All and for the invitation, and allow me to switch to Arabic. يعني أنا بس عاوز أقول bullet points سريعة بالنسبة لمصر.
I have some bullet points in respect of Egypt. As a matter of fact, the current government has all the determination to achieve
Tokyo Declaration
the Tokyo Declaration, which I have attended myself, to achieve universal health coverage by 2030 government. We have all the political commitment to achieve this. We will be allocating all the necessary funds in order to make this a success. Egypt has a special privilege. It has started health insurance since 1961. So this is not a new thing to us. It's something like 54 years now. Unfortunately, for certain reasons, health insurance did not meet all its objectives. At the same time, the health sector could not develop a satisfactory model to deliver a good health service to the public. We have high fertility, it's about 2.5%, something like more than 2 million people every year, and this does not make it easy for the government to allocate enough resources to the health sector. But thanks to the new law, we are going to change this situation. So our new system, despite the fact that it is supposed to be a universal health coverage, we still maintain that it is a sort of reform of the total health sector that had been fragmented for some time in Egypt. What I wish to highlight here, that throughout our study to cover many models during 10 years in respect of universal health coverage, we found that there will be no one source that can effectively achieve universal health coverage, not only taxes or subscriptions, not state budget can be the sole player. And this is the kind of model that we have developed in Egypt. We have merged through sources, subscriptions, state budget allocations, as well as a set of taxes that are dedicated, which is outside the state budget. So 1/4,000 from all sources of finance, 1/4 out of 1,000, in addition to taxes on tobacco, cigarettes, on high roads, and without having to pass through the state budget in order to cover financially this new system. Besides, we did not have free hand to determine what is to cover and not to cover, because according to our Egyptian constitution, it has been provided that there must be universal health coverage and that all diseases must be cured. So our new law must have been consistent with our constitution. We have been working over 15 years because the law said that I'm not only covering the individuals, indeed the whole family in Egypt, not only the person or the Egyptian who is employed by the government or in the civil service. I'm dealing with the whole family. I have to cover the whole family, either through subscriptions to be paid by them, or in case of failure by the individuals, the government will be intervening and it will be paying the subscriptions. We have made a complete division between the system and the state government and the state budget. We have not been repeating the same old experience depending wholly on the state budget. We said that we must have something independent from the government, and we have had a sort of study for more than 11 years to ensure sustainability of the system and to have a good quality service depending on partnership between the government and the private sector, so that we have a good quality service. Even monitoring and supervision should be outside the government. The monitoring authority will have to report to the President of the Republic, to Parliament. It is not going to be supervised by any state authority because it will be responsible for quality service. There is an authority to deliver the system. It is going to purchase the service from the private, from the public, from the military sectors, because our purpose is not to confine the service to state institutions. Indeed, to all our individuals, all Egyptians must get the service from any source, because there is one source that is funding this service. It will be coming from all sectors. That's what I wanted to give you as an overview. We have political commitment at the highest level of the state. Were it not for this commitment and the fact that we have been working for 11 years to pass this new law on health insurance in Egypt, were it not for this political commitment and support, we wouldn't have been able to achieve this in terms of a new law. That's why I want to hail and greet Parliament, because they have provided full support and they have been helping us to find out new funding sources. Thank you so much.
For this intervention, and we shall hold you to your promise. That's a commitment pledge made here today. Any questions, please? Just raise your hand and you have the microphone in front of you. Introduce yourself and say who the question is for.
I'm Dr. Wagida Anwar. I'm a professor of public health and member of the committee which was drafting the law in Egypt. Dr. Ma'id, of course, mentioned everything, and Dr. Ramat Kazem, but I would like to focus on that the law, of course, we acknowledge the signing and approval of the new law. It's an accumulation of effort for many years, and since you mentioned Dr. Tawfiq Shusha, I would like to mention here Dr. Abdelwahid Al-Wakil and Dr. Nabawi Mohandes. You know, Egypt has a very good network of primary health care, and I'm sure it will be integrated in the new system. And in 1996, there was a health sector reform program. Maybe this is did not sustain because there was no law. Now we have the opportunity, we have the law, and the law is the basis of the reform. So I hope that this will be continuing and implemented. I want to emphasize about the importance of public health and the prevention programs, and the importance of integrating different vertical programs in the primary health care. This way we will make sure that all the aspects will be covered to achieve the universal health coverage. And also the new law in Egypt allow, as Dr. Maïs said, the contribution of private sector, the civil society, and it doesn't neglect all these sectors, which really, as it was mentioned, that the out-of-pocket from the patients is in Egypt between 60 to 70%, and this goes to the private sector and the NGOs and so on. So integrating all these efforts in the system, I'm sure this will be helpful to the universal health care.
Thank you. Questions, please. The young lady at the back, yes. The
مايكروفون لو سمحتي. مايكروفون فضلك.
I think I have a pretty loud voice, but I can use this as well. I want to say, first of all, thank you very much for your very insightful presentation. My question is on behalf of the young people. So what's the role of young people in contributing to universal health coverage, and how do we train us young people? So this is the end of the panelists.
Who would like to answer this? Shall we answer? Young people.
From Sudan.
No, we're answering the question first.
Let's take that and I will
we'll take all the questions. Okay. Where's the lady from Sudan? Please.
The lady from Sudan is sitting in Khartoum, the capital of the two Niles, where they meet. My name is Naim Al-Qasir. I'm speaking from video conferencing. I would like to congratulate all the panelists, of some whom I have worked very closely, to say how we can engage the young people. I will give my experience as a fourth grader, 7 years old, in my little school in Bahrain, where we were told about the World Health Day and the importance of cleanliness and environment and sanitation. Age of 7, Constitution of WHO, what health means. Health means promotion, prevention of disease, curative care loss, and then rehabilitation. As at age of 7, we had to have the best class, best school, best neighborhood, best streets, and as young people, we mobilized on how to do it. Today, since I have this opportunity, Ustadha Shahira, I will just give also my intervention. It has shaped my thinking, my behavior in the last 23 years also with World Health Organization. Young and youth, Girl Guides, Boy Scouts, the sports, they are brilliant sources to bring the health promotion, disease prevention through a healthier lifestyle. Today we are talking about health in all policies, wherein Sudan is one of the countries that have done this with highest political commitment. It is focusing, moving away from the medical model, moving away from health facilities, big hospitals, technology, and going towards ensuring safe air, safe water, safe drug, safe technical competence of the whole healthcare team, safe food, safe blood transfusion, safe technology, safe clean environment, which I learned at age of 7 to the person who questioned. Building on the evidences built by World Health Organization, I see Dr. Walid Al-Ammar. He is the first person I worked with as a WHO. I don't know whether he remembers, but I remember very closely we were talking about prevention then. Then going forward to today in Sudan, we are working also, as Zafar said, not only the health sector partnership, but today, in this week especially, intensive work, not only to bring the resilient communities under community-based initiatives, but also how to get reaching the highest number of population through a high-level commitment of health financing to reach the poor, not to be the poor, to reach the disabled, refugees, returnees, nomads, ensuring everyone is contributing through partnership, fighting the poverty. Today, I want to bring one new switch to the team that I did not hear under sustainable development, health in all policies, given our context in the region where we have so many emergencies, natural and unnatural. How can we look into new financing strategies and interventions in partnership with all? Sudan is being now testing it. New coordination of mechanisms, not only between the UN agencies, but also with facilities and funds, with the governments, with the people, with the communities, to reach the positive health that is affordable, accessible, acceptable, available, and accessible. Also, I want to add, since Dr. Ruwaida spoke about the changes in the human resources, the move from physicians' model to actually a healthcare team that is protected, that is given the opportunity to be functioning in any settings where nurses and midwives and community health workers are the pillars. This is all the three new ways are being tested in Sudan, with the government of Sudan, with the parliament, and also with all international community, which includes the donors. What lessons learned would be something that WHO would share with everyone. In conclusion, I would like to bring the insurance of people-centered focus, which Dr. Walid mentioned too, and the Pakistan distinguished representative, linked to the health insurance coverage. WHO supported Sudan with the new health financing policy. Very happy to say, like Iran, they can now say how many percentage of people are covered. Long way to go, but the measurements and monitoring is happening as advised by WHO experts. Protecting everyone is a core. I would like to bring one niche, building the resilient communities, people, under promotion of health prevention of disease, investing in vaccines and investing in health, is a responsibility of all of us according to the preamble constitution of the World Health Organization. Health security is responsibility of the persons, people, and the states, and we add communities. Finally, I would like one thing to leave for us for a thought. Each of us wants the best for each one of us. And final statement, ethics of partnership, ethics of going back to the principles of our ethics. What does it mean? Collaborations, partnership, coordination, and our individual and collective responsibilities. Thank you very much for giving me this opportunity. Really appreciating these interventions by all the experts. Thank you.
Thank you very much. I think before we move on to the next question, Dr. Ruwaida has something to say about the role of youth.
I think the youth and the children, you are the backbone of what we're doing. Because, you know, this is for your future, actually. And you have many things actually to do. One thing is to champion initiatives because, you know, about the lifestyle among youth and children. This is very important. We're talking about the disaster actually in the communicable diseases. And, you know, in our region, we have the majority actually of youth, and we have problems, heart problems, diabetes. You know, the rates, they are, you know, going up. So I think if you are working like champions, you know, as advocates also for health, and health promotion, this will be great. You are actually at the heart of what we're doing. We're working, and you are working with us, with you, for you, and for the next generation. That's what's the power, about the universal health coverage.
الأجيال القادمة أنني أجد كثيرا من الأيادي المرفوعة للمشاركة ولكن من خارج منظمة الصحة العالمية. تفضلي سيدتي. الصوت.
Okay, I'm Shahrazad Ghazi, Dean of the Faculty of Nursing at Badr University, a private university in
عميدتي في إحدى الكليات الجامعات الخاصة هنا في القاهرة. إنني أود أن أوجه السؤال إلى الدكتورة.
We have a really big problem.
لدينا مشكلة كبيرة هنا في مصر. أعني في مصر.
We are a culture of safety, prevention of illness,
بالنسبة لثقافة الأمان والوقاية ولكن الإرادة السياسية ليست على نفس المستوى. فإن كثير من الوحدات الصحية يتم بنائها ولكن ما زال هناك الكثير للعمل على مستوى المجتمعات المحلية ولكن نريد أن نعرف وأن نشارك ونريد أن نحدث تغييرا ولكن للأسف فإن التعليم والممارسة شيئين منفصلان عن بعضهما البعض. فكيف يمكننا أن نحل هذه المشكلة؟
Thank you very much. Our reading sitting in WHO and looking at the leadership in Egypt and the policy actions they are taking is that I can confidently tell you that things are changing. And obviously, if they have to provide universal health coverage to all the population, the focus has to come down from tertiary level to the primary health care level. And I think that's where focus seems to be right now. Without that, everybody cannot be covered. It's as simple as that. So I think, yes, there have been problems, but I think eventually, finally, we seems to be getting on the right track, especially with the social health insurance.
Any questions from the media?
هل هناك أسئلة من جانب وسائل الإعلام؟
Thank you. I want to thank all the panel for the interesting talk and also to congratulate the World Health Organization for the Health Day. Let me introduce myself. My name is Laila Abu Ismail. I'm a member in the health community in the Egyptian Parliament. I was very proud to share in the discussion with all the members, all my colleagues in this health committee, and of course with the government and with the excellencies, the Minister of Finance and the Minister of Health, and also the Vice President, Dr. Munayr. Let me talk about sorry. Yes. Okay. So I want to tell you about the discussion that was held in this committee. It was very strong discussion, and our main goal was to defend the poor population and to know the definition of who is the low socioeconomic sector that the government will be responsible of covering them completely. And we did a lot of effort, and at the end we have some sort of definition. We hope it works. Another thing that the negative thing that we thought that the charges that all the families have to pay, the participation, we thought it's a big load for the Egyptian families, the middle class of course, but we're convinced that the sustainability of the fund should be held as they were discussed. One positive thing of this health, of universal universal health law, universal health coverage law, that it completely cover all chronic diseases and all sorts of cancer disease, and which is very good because this is the financial burden of all families, even the middle class or the low class. It's a financial burden. So the law is very good in this point. We have to emphasize on it that it covers all the chronic diseases and the cancer-related diseases. But my question to Dr. Soket, I don't know if she can hear me or anybody can answer me, that the goal of the WHO used to be on the communicable and non-communicable diseases and prevention, protection, and child health, and put programs for this. I see that Egypt has took a big role in this. We need the attention of the WHO in programs that help in the family care units, family health care diseases, and the doctors, and the primary care units, which is the milestone of health insurance. So I want to know if there is any change or optimistic programs of the WHO towards our universal health insurance law. I would like to hear about this. Thank you.
Thank you very much. Do you hear me?
Yes, finally.
Welcome back.
Finally, and my apologies for whatever technical issues arose, all my excuses. Yes, the answer is WHO sees the control of disease and addressing promotion of health and prevention of disease as well as treatment of disease as an integral part of universal health coverage. Universal health coverage is about access to services when people need them. So it includes the response to any kind of illness, but it also includes promotion, prevention, curative and palliative, which means it also includes programs that address the underlying reasons why diseases occur and preventing these diseases, for example, through vaccination, child health services, preventive child health services, and maternal health, including antenatal care and all the care around delivery. What I really want to say at this point is that all countries can do something about QHC. It's not a matter of resources only. Let me take a few examples. All countries can implement what we call health taxes. We generally know the tobacco tax. We know smoking is really a very important risk. It's a major risk for people to smoke in terms of cardiovascular disease and cancer. We know that introducing a tobacco tax can make a huge difference, particularly on young people, delaying or not starting, not initiating the smoking. So introducing a tobacco tax is very important. Recently, we're also talking about taxes on sweet beverages. So introducing taxes on sugar products is extremely important, particularly in the Eastern Mediterranean region, where we see a rising trend of obesity, particularly among children, but also women, and we see a rising frequency of cardiovascular disease, diabetes, that will cost a lot to the society. If we don't now introduce those taxes, this will create a lot of diseases in the future, particularly diabetes, cardiovascular disease, and other diseases linked to obesity. And this will be a very high cost on society. We see most of the cost of UHC right now, and the cost that is increasing is around those lifestyle diseases, which are linked to lack of exercise, poor nutrition, particularly consumption of sugar and consumption
المستثمرين
also
وأيضا
of
أن نعيد
tobacco
النظر
and
في
alcohol. So that's the first thing
استهلاك
that every country can do
المواد
without
السكرية. هناك
resources.
الكثير من
Just
الأمور يمكن أن
applying
تقوم
the
بها
right
الدول
tax to
وليس
the right
فقط
product
الأمر
so
يتعلق
that
بالموارد
people would use less of this
المني.
product that is actually damaging to
على
their
الناس أن
health.
يستهلكوا
The
أقل
second
هذه
thing is
المواد
really
حتى
the
نتجنب
promotion of healthy lifestyle.
هذه
And
الخسائر
that
في
can be done
الصحة.
to communication campaign. It was mentioned
وأيضا
by
لابد
several
أن
of
يكون
the
هناك
distinguished
حملات
speakers and also
إعلامية
people in the room.
والتواصل
That the part of promotion can also is actually extremely cheap. It's a few dollars per person per year. It's a very tiny proportion of the Ministry of Health budget. And that is really something that can be done by all countries. Campaigns of promotion again about healthy lifestyle, seat belts, road bumps, the prevention of injuries, which also is a major problem in the region, is something that can be addressed just by information, communication, education. So a lot of the cost can be avoided by actually preventing the illness, preventing the accidents, and that every country in the region can do it. And now, of course, we go to the quality healthcare, and there is different types of healthcare. There are really what we call the best buys or the low-hanging fruits. They are really interventions that cost very little and make a huge difference. For example, when the child has fever and is coughing, he has a pneumonia, giving a treatment with antibiotics costs very little. But still, in the region, there are entire groups who cannot access these treatments because they have to pay for it, and they cannot find it
يمكنهم أن يحصلوا على الخدمات ولكن هناك كثير من المجموعات في مناطق مختلفة لا يستطيعون أن يحصلوا على الخدمات الصحية لعلاج هذه الأمور. طبعا أن
birth delivery of women, particularly among poor women in rural areas and peri-urban areas, they still don't have access to these services. Access to services for people with diabetes, with people with hypertension is also a problem in the region. And also the high quality, the high cost of healthcare, it was mentioned by my colleague Dr. Zafar and by others. We know that in the world there are 100 million people who actually get impoverished because of healthcare. 800 million people spend more than 10% of their household budget. So what sometimes is forgotten, how universal health coverage is also a safety net. It's a program that not only helps with health, but it also helps with poverty reduction. It's a very powerful poverty reduction policy. So there are really a series of services that don't require major amounts of funding and that can be delivered by any country, and particularly any country in this region. Thanks.
Thank you very much, Dr. Souket. We're really happy that the link has been restored. From Geneva, we now go to Morocco to hear from the World Health Organization representative in Morocco. Video link is ready with Morocco. So shall we take a question until it's ready?
Thank you very much for this elaborate panel discussion. I'm Professor Dia Marzouk, Chair of Family Medicine Department in Ain Shams University. I'm going to speak about, I'm not going to ask a question, but I'm just to raise a talk about the training of family medicine physicians, who are the pillars of the new law, and family medicine physicians and nurses. training should be very rigorous in our country. We are starting collaborations with the Ministry of Health as universities to reach or to acquire the work-based competencies of the physicians, because as I've known about the primary care job description, they should be specialized family physicians, not only just graduates of the medicine. So it will take a lot of work and hardship, but it's promising, and there is a very good thing rising in Egypt now is the private family physician centers. They are rising, and they can collaborate as private sector with the Ministry of Health, and this is a new issue that we have to encourage. That's all. Thank you.
Thank you. All right. Is the Libya link ready? Libya or Morocco? No. Until
I think you raised an important issue. The WHO actually, they have great work in the area of interprofessional education. So we have to emphasize the interprofessional education. Even, you know, talk more about prevention, because students, I was president of one of the universities, they love to work in hospitals. They don't like to go to primary healthcare centers. We have to change that. We have to emphasize the practicum of the students outside the hospitals. Hospitals are not actually the only place, maybe the last place that they have to go to in training. So the interprofessional education, I think, is one of the things that in a region, and I'm talking to the WHO, you know, people around, really we need to concentrate on that. You're talking also about the professional competence of healthcare providers. This is very important, and also now the world is including the global health competence. And actually, we're going to do a study with that. But I think this is another thing. We have to transform the education system in our region. I think this is very important. And that also was one of the recommendations from the High-Level Commission, as well as from the Nursing Now campaign, is the transformation of education, emphasizing the interprofessional education. Thank you.
Can we please take WR Morocco or Libya? My IT colleagues. I can see Dr. Jafar, for example. Dr. Jafar, can you try to speak, please, if you are listening to me? No, he can't hear me.
Can I have a question? Can I have a question? This is Sudan.
Yes, Sudan is allowed to ask.
Question to the panelists. Until we have my colleagues from Morocco and Libya on board. My question is reference to the expenditure on health and the GDP. From the distinguished guest, do we have a formula that we have been able to calculate the investment, for example, in the safe roads, the investment in safe food, the investment in safe water? Is there a kind of a calculation or a formula to show how much the governments are spending, not only from the health, but from the other Ministry of Health, but from other sectors?
Mr. Majid.
Frankly, we don't have it. I mean, you're absolutely right. There are sectors which invest into health sector, but we don't have it, and that's a very good thought, by the way.
I think, you know, there is a lot of studies in the process of measuring, you know, the impact of investment in health in the different areas, you know, and let's talk about, you know, the chronic illnesses. Let's talk about, the safety, roads and others. So Lancet group as well as the WISH group, they are working on such studies. I think the evidence is very important. We have to keep providing the evidence, creating the evidence in order to submit it to the policymakers and politicians. And also for us to know how to go, where should we go, where are we good and where are we bad. Thank you.
We'd be happy to leave it at that with a final round of very, very quick comments and maybe pledges, more pledges and promises, and hopefully we did achieve a lot today, but unfortunately Libya and Morocco couldn't be with us because of the video links. So starting with you, Mr. Majid, and we go round and
هناك من يتصل بنا يقول ألو.
We are very clear as far as Capital 25 is concerned. It's universal health coverage. It's not equal access, which will take time. It's equitable access of every citizen to healthcare. That's the message that we have.
Well, I think we should understand that universal health coverage is very much context specific, and it depends on the history of the country and the nature of the health system, and who are the players in the health system and their capabilities. So there is not one solution that fits all countries, and we should learn from our experience in order to move forward. However, we should understand that although it is the duty of the government to make sure that the system is functioning in an equitable way, we should not neglect including other partners as much as we can and diversify resources.
So although there's no one-size-fits-all, but countries can learn from each other's experiences and share lessons.
Thank you. I think some key things have come out from this discussion, this panel discussion, what panelists have said and different participants have also raised. I think it is very clear by the end of the day that I think we all agree that universal health coverage is the way to go about. That's I think a consensus among everybody today in the world. The second thing is that every country can do something about it. It's not limited, it's not the privilege of the more resourceful countries. And the third, I think, very important thing is that we need to also create demand for universal health coverage, and by that I mean that the citizens need to get involved. There should be a citizen's voice. There should be a demand for better health care, especially the young people. And with that reference, I also want to say that universal health coverage is a journey. It's a progressive advancement, and it's an intergenerational thing. It's not just that we will push the button and we will have universal health coverage tomorrow. It's a long-term journey. And this is why it is very important that we invest today to the policymakers of tomorrow. And that's what, by that I mean that the young people, the young health professionals today needs to know about their national health systems. Universal health coverage should become part of the medical curriculums, not just for doctors, but also for nurses, for paramedics, for other health professionals. And actually, we are now investing to develop a curriculum on universal health coverage, and which we are going to launch, inshallah, towards the end of this year. And we will then be working with the governments that how this curriculum can become part of the medical education and training for different cadres of the health. So I think that I'm really, really thankful to all the panelists and all the brilliant comments that have come about, and we feel encouraged that we are taking the right road. Our Director General, Dr. Tedros, has actually invited 194 member states to actually announce 3 key actions that they will be taking in terms of advancing universal health coverage and announcing those during the World Health Assembly in May this year. So this is also a take-home message to work with our governments that what they can announce at that global forum, that how their governments will be taking action and what actions they will be taking to advance universal health coverage. I thank you very much.
Thank you very much. I'm so happy to hear about the education, and hopefully it's an interprofessional education. I think again, I believe that the universal health coverage is an investment in human capital. It enhances definitely the socio-economic as well as the national security. The challenge is the sustainability as well as how we're going to monitor and evaluate our progress. I think we have to have that system in order also to measure our successes for the future. Thank you.
بسم الله الرحمن الرحيم. في النهاية بحب أشكر
In
جميع
conclusion, I would like
أعضاء
to
البانل
thank all
على
the
هذه
panelists
الاستضافة
for having
وبكرر
hosted us,
شكري
and I would like to reiterate my
للقيادة
thanks
السياسية عندنا
to
اللي
the
هي
political
دعمت
leadership
هذا
that
المشروع إن هو
supports
يطلع
this
قانون التأمين
project,
الصحي
which
الشامل
is
بعد
issuing
دراسات
the
عدة سنين إن
comprehensive
هو يظهر
natural
إلى النور.
insurance law
وبشكر
that
جميع
finally has
الإخوة
come to
الزملاء
light. I
من
would like
وزارة
to thank
الصحة
all
اللي
my
تعبوا
colleagues
معانا
from the
جدا
Ministry of
لإصدار
Health
هذا القانون.
to have
وبرضو كان
supported
معنا
us in
دكتور معين
issuing this
من وزارة
law.
المالية.
And we do have Dr.
ويمكن
Main from the
بنشكر في
Ministry of
النهاية
Finance,
الإخوة
and
الزملاء
we'd like
في
to
البرلمان
thank our
المصري
colleagues
اللي ادونا
in the Egyptian
الاعتماد
Parliament.
والموافقة على هذا القانون
Without passing
في
this
وقت
law
يعتبر
in
قياسي
a very short
ودار
time,
عليه حوارات
and
نقاشية
around
كتير
which lots of
في لجنة
discussion took
الصحة.
place
فأنا
in
بشكر
the Committee
الإخوة
of Health. I
الزملاء
would like to
من
thank
لجنة
my
الصحة على
colleagues
اعتماد القانون،
from the
وإن شاء الله يكون حاجة
Committee
مبشرة
of Health, and I hope
لمصر إن
that
شاء
this law
الله.
is going to be very
شكرا.
promising for Egypt. Thank you.
Let's give them a big hand, our panelists for today,
جميعاً.
Dr.
أرجو أن تحيوا
Ahmed,
معنا
Dr.
الضيوف،
Ruwaida,
دكتور
Dr.
رويدة،
Zafra,
دكتور صفا،
Dr. Walid,
ظافر
and
ودكتور
Mr.
وليد
Abid.
السيد.
Thank you. And last words from Morocco,
كلمة من
actually,
المغرب.
because we
أعتقد
do
أن
have
المغرب
the
قد
Moroccan
استمع إلينا والآن
representative.
نتواصل معه.
Do you hear me?
Loud and clear.
تسمعونني؟
Now you hear. Great. Fantastic. Thank you very much. I'm very privileged to have the last word on this. I just wanted to mention that during this very interesting and very inspiring panel, we have heard a lot about people and values. And I would like to say that this is really related to the importance of governance. Not government, not only government, but governance. And I would like to end this debate by linking our goal, which is SDG 3, to SDG 16, which is about peace, about governance, and about building strong institutions. And for many countries, for all countries in the region, the path towards universal health coverage is primarily about strengthening, building, rebuilding strong, inclusive institutions. And that will also include including the vulnerable people, the neglected population, the women, and all the different portions of the population that feel excluded from this path to universal coverage. So the link between SDG 3 and SDG 16 is something that will be critical and central. And building partnerships around governance would be extremely critical for our path to universal coverage. I don't want to take more time on this panel, but many thanks for
الصحية الشاملة وأشكركم جميعا على مشاركتكم. شكرا جزيلا على المتحدثين ونشكر كل من حضر هذه الحلقة النقاشية معنا. وأنني أود أن أقول لكم أن هناك حفل غداء سوف يتم تقديمه وشكرا لكم.